Good afternoon or good morning to everyone, depending on what time zone you're in. Welcome to our webinar today. This is our second virtual convening of the CHW Sustainability Collaborative. During the previous webinar, we explored how to use language in Medicaid managed care contracts to support community health workers, and today we'll be talking about another funding pathway, Medicaid state plan amendments. Just a few housekeeping bits to get out of the way first. We are recording just the presentation part of today, so that we can post the recording as well as the slides on our CHW Sustainability Collaborative Resource Hub. They'll be there for all of you to access as well as for others who weren't able to attend today. And once we have those posted, we'll be sure to send out an email to everyone on our collaborative list. But we will turn off the recording when we get to the Q&A portion, so please feel free to ask whatever questions you may have or just share with us what's happening in your state. We love to hear updates and hear what other states are considering this pathway or other funding pathways for community health workers, and we want that to be a time where you really feel comfortable just kind of speaking openly. Right now, everyone except our speakers are muted. We do have, it looks like, close to 60 people on the line, so we wouldn't want to have everyone unmuted. That'd be a little unwieldy. But you can put a question in the chat box at any time during the presentation, and we'll flag those to be answered during the Q&A. During the Q&A, you can unmute yourself by pressing *7, and then we ask that after you finish your question to please press *6 to remute your line. And we'll have these instructions up at the last question slide as well, so no need to write them down now if you'll be waiting for questions. There's also a quick evaluation that will pop up when you close out of the webinar today, and we ask that you fill that out because we really do want to hear from you on how this webinar went, how useful it was for you, what we can improve on, and what topics you'd like to hear about on future webinars. All right, we've got a great speaker lineup for you all today. My name is Ellen Albritton, and I'm a Senior Policy Analyst here at Families USA who works with our CHW Sustainability Collaborative. I'm just going to go over a bit of background and introductory information, and then I'll get out of the way and turn it over to our really great speakers we've got lined up. First will be Joel Urweis, Associate Director of Regional Asthma Management and Prevention, who will talk to us about California's efforts. And then we'll hear from Jessica Holmes and Erica Selesky, who have been working on a state plan amendment and other payment efforts in Missouri. So quick intro, just in case there are any new folks on the line who aren't familiar with Families USA. We're a national nonpartisan healthcare advocacy organization dedicated to the achievement of high quality and affordable healthcare and improved health for all. And given our commitment to health equity and to ensuring healthcare value, making sure that there's sustainable funding for community health workers is really a no-brainer for us. As many of you know firsthand, community health workers can be such powerful change agents for their clients and for their entire communities, but too often a lack of sustainable funding prevents or remains a serious barrier to fully unleashing this power. And that's why we started our Community Health Workers Sustainability Collaborative. And just one quick note that, mostly you'll hear myself use the term community health worker, and that's in the title of our collaborative. We do want to note that we're really using the term to refer to any folks who are trusted members of their community and who serve as this bridge and this link between the healthcare system and the social service system and their communities, but who could go by any of these titles and even some titles that aren't listed here. So we really take an inclusive approach, and we want to see all of these folks have access to more sustainable funding so that they can really do their best work. And just to give you a very quick high-level overview of what a state plan amendment is and how this is a pathway to funding for community health workers. A state plan amendment is really just a change to a state's Medicaid program. A state must submit that application for the amendment to CMS, and CMS must approve it. These are relatively easy and straightforward, at least if you compare it to Medicaid waivers, which is another way that states can make changes to their Medicaid programs that you may have heard about. But state plan amendments, which is often abbreviated to SPA or referred to as a SPA, can be used for much smaller changes to reimbursement or services, and it's not unheard of for a state to submit a couple of SPAs in a single year, and they kind of just extend forever, whereas a waiver is something that's for a limited duration. They're much larger changes typically, so you wouldn't be doing multiple of them in a single year or even in back-to-back years. In 2013, CMS made a change in regulations that allowed for non-licensed providers like community health workers to provide preventive services, as long as those services are recommended by a licensed provider. This is really exciting as it opened up a new pathway for community health worker funding, and to access funding for community health workers through this pathway, states need to submit a state plan amendment. So that's why we're talking about a SPA here today. This change was both really exciting, but it also brought up some considerations for community health workers and for advocates, given that this pathway does have, some particular requirements under federal law and some potential limitations. And I know our speakers will talk more about those, so just to give you a very quick introduction, first, a state plan amendment, it's still what we call fee-for-service, so providers are still reimbursed for each service that they provide. This is in contrast to what we see a lot of momentum right now about a transition to value-based care, where providers get paid based on outcomes and not based on the number of services. And we know that so much of what community health workers do don't necessarily fit into these 15-minute or 30-minute billing codes, reimbursement codes that we've set up in our healthcare system. The definition of preventive services under this approach is also kind of narrow. It has to be directly related to an individual's physical or mental health. So, community health workers do so much great work at the community level, these community-level preventive efforts, and those really don't fit in this kind of medicalized model of prevention that we see. And while certification, as is often talked about and implemented, is not necessarily required for CMS to approve a preventive services SPA, Medicaid programs do have to include in their application the training and the education requirements for these non-licensed providers. And we know that many Medicaid offices are in favor of the certification approach. And we've talked in previous webinars and in materials about some of the considerations for advocates when thinking about certification. So just some things to keep in mind, and I know our speakers will be diving into different elements of these issues as well. So with that, I will turn it over to Joel.
Thanks so much, Ellen, and it's a pleasure to be here. And thank you to you and the team at Families USA for the opportunity to speak with you. I want to let everyone know that I do have a bad cold, so if I suddenly go mute for a little bit longer period of time, that's just me sparing you from listening to my sneezes or coughs, so bear with me, please. I want to start with a quick word about RAMP, Regional Asthma Management and Prevention, for those that aren't familiar with us. We are a project of the Public Health Institute based in Oakland, California, and we reduce the burden of asthma through a comprehensive approach, which ranges from clinical management to environmental protection. We use a variety of strategies across multiple goals, including improving indoor air quality in housing and schools, reducing outdoor air pollution, and linking clinical care with prevention. So in the next 15 minutes or so, I'll walk you through the asthma and community health worker related goals we have here in California. The State Plan Amendment, or SPA, of course, is one key part of how we're moving forward. I also want to highlight many of the lessons that we've learned here in California from our work on the SPA, and whether you're just beginning to think through how a SPA might work for you in your state, or you're deep into this work, my hope is you'll find something useful to advance your own efforts. So what are we trying to do? Well, at a very broad level, here at RAMP, we're trying to better link high-quality, culturally appropriate healthcare with community-based prevention efforts. More specifically, we're trying to increase access to patient education and in-home environmental trigger remediation, particularly for people with the highest burden of asthma. In doing so, we hope to improve the sustainability of new and existing in-home asthma programs. And importantly, we also want to strengthen the healthcare workforce, including community health workers and other non-licensed professionals. We have been, for a very long time, big proponents of the home visiting model. And consistent with the National Asthma Guidelines, patient education and environmental control measures work. We know this based on a voluminous amount of quality research. These interventions have proven tangible benefits. That includes better health outcomes like reductions in ED visits and improved asthma control. These services also have a financial benefit with a strong return on investment by reducing more expensive healthcare utilization costs like hospitalizations. Then there's the equity impact. So as you probably all know, there are significant asthma disparities, and poor quality housing is one of the environmental inequities that contributes to those disparities. So by targeting Medicaid through a SPA, that's one avenue for us to better address the negative impacts of substandard housing on health. Reaching the Medicaid population translates into reaching the racial and ethnic groups facing asthma disparities. As it happens, we used all three of these messages, so health improvement, saving money, and addressing disparities, in much of our messaging with policymakers, which I'll talk more about in a little bit. So how are we going about this work? Using a SPA to implement Medicaid's CMS rule change that Ellen mentioned, we call it the Preventive Services Rule. This is without a doubt one of the key opportunities that we've been pursuing. When the rule was in development, we saw it very much as a game changer for our work. And that's true for a variety of reasons. First of all, California has long benefited from the involvement of community health workers and other non-licensed professionals in a variety of home visiting programs. CHWs in particular provide, as you all know, a level of community connections and cultural knowledge that's often essential for proper asthma care. However, the challenge really is that funding to sustain these programs has been exceedingly difficult to find. Most programs rely on grant dollars from private foundations. Where Medicaid dollars are involved, they're typically limited to administrative funding from managed care organizations, which is pretty limited. So for us, this rule was a means to tap into a much broader pool of Medicaid dollars. I should say here that the rule is but one effort that we're pursuing, and I'll say more about this in a moment, but the point I want to make here is that our efforts to adopt the rule are one of several that we're pursuing. Okay, so the status of our SPA. The work on the rule has been a really long and winding road, and before I get to some of the lessons, I want to walk you through some of the twists and turns that we've experienced. As you know, as Ellen mentioned, the rule became an option for state Medicaid programs to adopt starting in 2014. At that point, we focused on essentially climbing the steep learning curve to understand how the rule might work here in California. We also started talking about the rule with a wide range of partners to get their perspectives and to explore some collaborative opportunities. And it was also at this stage that we decided to focus exclusively on asthma rather than multiple health conditions or a specific type of workforce. And I'll talk more about that in a little bit. So asthma stakeholders here in California have a really long history of collaboration, which is great. But in 2015, that was a period where there was a lot of deepening of relationships, specifically related to financing in-home asthma services. That included the launch of the California Asthma Financing Workgroup, the members of which have served as really key partners, allies, and sounding boards in this work. 2016 was when we got into the nitty-gritty of developing the state plan amendment. So in close consultation with partners, we worked with leadership at our state Medicaid program, it's called Medi-Cal, to draft a SPA. Pursuing the SPA for us also meant pursuing legislation. So Medi-Cal leadership informed us pretty early on that the program didn't typically adopt a SPA or pursue a SPA without the blessing of the legislature. And that may not be the case with Medicaid leadership in other states. It's certainly true here in California. So as a result, in 2017, RAMP, Children Now, and the California Pan-Ethnic Health Network co-sponsored AB 391. It would have provided the statutory authority or the approval, essentially, from the state legislature to move forward with the SPA. So our bill passed with bipartisan, near unanimous support, something very unusual these days. And we were feeling exceedingly optimistic about our efforts right up until the governor vetoed the bill. So undeterred, we dusted ourselves off and re-engaged both Medi-Cal and the legislature. Long story short, in 2018, we started to work through the state budget process. So the idea here is that the legislature would appropriate funding for in-home asthma services, and then with funding in hand, Medi-Cal would then pursue SPA approval with the federal Medicaid program. So again, the appropriation received bipartisan support and made it into the legislature's budget. So we were feeling cautiously optimistic right until about 10 days ago when the final budget agreement between the legislature and the governor was announced. And that budget deal, unfortunately, did not include funding for in-home asthma visits. So we are still in a little bit of state of shock and sorrow, and we're busy gathering information about what happened. Fortunately, from what we've heard so far, it seems that the rejection was not related to the merits of our specific ask. The elected officials seem to prioritize social services and the state's rainy day fund. Major investments in healthcare were left out, and that's likely due in part to some election year politics with the governor's race and other races happening this November. And as part of that, it seems many smaller health-related appropriations like ours were also lost in the process. Okay, so with that whirlwind of an overview, I want to transition now to talk through some of the lessons we've been learning as part of this process. Some are a bit simplified given the time constraints today, but hopefully they'll still be very useful. So at the top of the list is the need to be flexible and persevere and learn, and forgive the comic here if it's a little too informal, but over the last couple of weeks, humor has certainly helped. If someone had told me that the path of the last 4 years, particularly the last 2, would have been as winding as it has been, I would have been doubtful. If there's a lesson here, it's that this work does take time, and setbacks, I think, are the norm, honestly, not the exception, and it's really helpful to take the long view. I think the other lesson is that flexibility is absolutely key. We were certainly not expecting the need to do legislation, nor to work through the budget. Maybe naively, we thought that if we could simply convince Medicaid to pursue a SPA, we would be set. The experience in your state may be different, of course, and having worked with a few other states, I can say that it is different at times in other states, and it may be more straightforward, but that's really the point, by which I mean you'll need to adjust to the particulars of your own state's process. And then lastly, there is a steep learning curve with this work, so be ready and willing to learn as much as you can. I think I have felled a small forest, given the number of reports I've printed out to learn more about SPAs and legislation and the budget. And we spent hours talking and sharing information with colleagues in an effort to understand what comes next. So our ups and downs with the SPA have also really reinforced the appropriateness, I think, of our decision early on in this process to pursue multiple policy pathways to support in-home visits. And why is that? Well, simply put, there typically isn't one single source that's likely to fund comprehensive and sustainable services at a system-wide level. So much like a river has multiple tributaries, a well-sustained asthma program typically needs multiple funding sources. Much of this is simply due to the fact that funding sources often can only cover one portion of in-home asthma services. So this is an infographic from the EPA, and it shows how different sources of funds can be braided or blended together to support a comprehensive set of services. I'm not going to get into the details since it's so asthma specific, but the question I think that's really important to ask of your own work is, to what degree will a SPA fully fund the range of services that you want to provide? I think that the answer to that is often, a SPA isn't going to cover everything, so it's important to cover multiple things or to pursue multiple things. Pursuing multiple sources of funding also provides some tactical advantages. As you've heard with the timeline overview a couple of slides back, pursuing a SPA, like policy change generally, is really challenging and uncertain at times. So by diversifying your approaches, you can maximize the chances you'll increase the overall sustainability of any program. Another key lesson is that it's really helpful to decide early on whether you want to use a SPA to address one specific disease or health issue, or use a SPA to address a wide range of concerns. And I think there are pros and cons to both approaches. A more comprehensive approach covering multiple health issues may provide broader benefits. If a wider range of partners is involved, a comprehensive approach may also marshal more political power as well, which can be really important. At the same time, a narrower issue-specific approach may provide a relatively more straightforward path for policy change. So, for example, when the rule became an option several years ago, we explored implementing it here in California with colleagues from a wide range of sectors, so not just asthma. Ultimately, though, we learned that Medi-Cal was simply not willing to entertain implementing the rule across multiple health issues, so we narrowed our approach to focus just on asthma. Our hope is that when we're successful, that will in turn help open the door for other issues. And I think many of our colleagues in other fields see it that way as well. We've continued to have the support of organizations that don't work exclusively on asthma, precisely because the hope is that it will open the door to other issues. So another huge lesson from our work on the SPA has been the incredible value that partnerships and collaborative relationships bring to this work, and I really can't stress this enough. I don't know of any group that has advanced a SPA all on its own, and frankly, I don't think it's possible. So what is it about partnerships that is so helpful? Well, probably a few obvious things. First, it's the diverse perspectives and expertise that those partnerships bring. healthcare systems are complicated, and so having experts to help navigate the ups and downs of changing the system is essential. Having partners to weigh in during the various policymaking processes was also absolutely key. So for example, when we were drafting the SPA, we were frequently in touch with asthma stakeholders to make sure the policy decisions supported programs already on the ground. A wide range of partners also helps open doors that would otherwise be closed. So when we first wanted to work on a SPA, we had an extremely difficult time getting the attention of our Medicaid program. Staff there literally wouldn't return our calls or emails. They've got a lot going on. One of our partners, however, managed to grab the director of the program and chat with her for a few minutes at an unrelated meeting. And just because of that interaction, she agreed to meet with us shortly thereafter, and it really got things moving. Similarly, having partners with a presence in Sacramento, that's our capital, was really useful as the various legislative and budget efforts move forward. Partners could literally drop in on staff and other decision makers for a quick check-in, which made the overall process a lot more successful. Partnerships also help tell policymakers that the issue you're working on is important. So of course we encountered setbacks, but I'm really convinced we would not have made it as far as we did without hundreds of letters of support, people being willing to testify at hearings, meet with legislators in their district offices, et cetera. And then on a related note, I think partnership infrastructure can also be really useful. So in our work on the SPA, we got farther and faster with the presence of the California Asthma Financing Workgroup here in the States that provided the infrastructure to keep people connected and communicating and collaborating. So another lesson from our work on the SPA is that it's a complicated, multi-step, multifaceted process, as I think I've made clear already. And given this dynamic, it's really helpful to have resources and partners that can translate complex program, technical, and policy information to make it more accessible to partners. Sometimes that was me here at RAMP. For example, I'd often provide updates to the statewide work group and field questions from other stakeholders in the field. And then sometimes we lean on other partners, particularly when we've worked through the nuts and bolts of the legislative and budget process. We also reached out to colleagues who recently and successfully worked through a SPA related to diabetes here in California. Their process was somewhat similar to our own, and so they could help translate some of the nuts and bolts of working with Medicaid. And then, as I mentioned at the beginning of my presentation, our work is designed in part to support the healthcare workforce, including community health workers and other qualified non-licensed professionals. Again, CHWs in particular can be such an important part of the asthma care team. The case, though, is that that's not necessarily a universal sentiment. As I know you're aware, there are some pretty intense debates about the role of CHW certification. And some states have embarked upon certification programs in order to make it easier for organizations to utilize CHWs, and other states, as you know, have resisted certification efforts for fear that they'll strip CHWs of the community connections that are such an important part of a CHW's role, or frankly create barriers to, for long-time CHWs to become certified. So for our SPA work in California, we did not want our efforts to unduly influence this debate one way or another. So as a result, our SPA landed on what we think is a pretty elegant solution. We focused on the skills needed to deliver patient education and home trigger assessments. And then ultimately such skills can be demonstrated by a variety of non-licensed professionals. That variety includes CHWs, as well as others like certified asthma educators and healthy home specialists. This approach is also sensitive to workforce capacity and availability issues. We were concerned that if we limited the SPA to a specific type of professional, be it a community health worker or other non-licensed professional, that there basically wouldn't be enough, there wouldn't be a sufficient workforce to fill the demand. So I know I have covered a lot in a fairly short amount of time. If you'd like to learn more, you're welcome to reach out to me directly. Also, I want to encourage you to take a look at a lessons learned white paper that we published late last year. It covers our work on the SPA and other policy issues in California, as well as efforts in a few other select states. It is asthma specific, of course, but some of the lessons can be generalized for whatever issue you're working on. And then if you are doing work on asthma in home visiting programs, I would really encourage you to take advantage of the free resources and technical assistance offered by the National Center for Healthy Housing. So NCHH works with groups and coalitions to advance sustainable financing for in-home asthma services. And they can pull in other TA providers, including RAMP. And then if you're not quite ready to commit to a formal TA program, there are other online learn at your own pace resources available from us here at RAMP, from NCHH, the EPA, and the Childhood Asthma Leadership Coalition. And then in closing, I will say that we're going to continue this work. Despite our setback with the budget, we think that this is still a very important issue given the value of this approach and the inclusion of community health workers. We think that it's still worth pursuing, and there are opportunities on the horizon. So stay tuned. I hope to be able to report back to you soon enough that we have crossed the finish line. We'll get there. So thank you, and I look forward to taking your questions.
Thank you so much, Joel. That was such great information. I think a lot of really great lessons learned for all of us on the phone, and particularly I know that healthcare advocates and community health workers are no strangers to flexibility and perseverance. So I think we can take up that charge. Next, we'll turn it over to Jess and Erica to tell us about all of their efforts in Missouri. Jess and Erica, take it away.
Good morning and good afternoon, everyone. Erica and I, in what we present today, really want to share our experience so far in Missouri, but we're really in the middle of the process, so we're hoping during discussion today to really not only share what we've been learning, but learn from you all as well. And we'd also like to just, before we really get into the meat of our presentation, take a moment to share what we really value from our perspective about the community health worker workforce. And so I can start, and then Erica, please feel free to add your comments. But what we want to really ground in and what we feel is important about this workforce is while community health workers are really valued for the way they connect, patients to the broader system, what we also see is this opportunity, if the model is allowed to be flexible enough, for health workers to be really transformative, not just in their communities, but to our health systems. In St. Louis, we really tried to take an approach of innovation and solutions by inviting community health workers not just to include their voice at tables, but step up into leadership roles. And as we've done that in the St. Louis region through what is becoming a more formalized Community Health Worker Board of Leaders and Community Health Worker Coalition, we're elevating that leadership even further at tables at the state as well. That kind of power, I think, of lifting up that community voice in those spaces and encouraging and empowering health workers to not just talk about how they're making connections in the health system, but to add their ideas to the design of things. That I think has been a powerful force in our state to making sure that whatever reimbursement structure is designed at the state level, it matches with what is actually needed on the ground to serve our patients. So the value for me, from my perspective, is there's a real opportunity if we're thoughtful in including their leadership, the health worker leadership, we can shift the way that community systems are designed. And Erica, please feel free to add more from your perspective in Kansas City.
Sure. Thanks, Jess. I think you did a great job in representing our goals and efforts at the state level and the power of what we're trying to do in our engagement work group. I would just like to share, and from the Kansas City region, I work with our Community Health Worker Collaborative, which is a regional coalition that works in both Kansas and Missouri, and I help to facilitate all of that work. And I would just, being there at the table and help recognizing the community health worker leadership in our region and helping to facilitate that voice into policy development that's being raised up to the state level in both states has been extremely rewarding And also I would just say that it's really the policies that we develop and promote are much stronger and much more representative of the community voice and the community health worker scope of practice, which has been really important and I think a major pillar of our success in the region. And that's it. We can jump into the presentation, Jess, unless you have anything else to say.
No, that'd be great.
Okay. I'm going to start, and then Jess is going to take over. We're first going to give you a little bit of background on the Payer Engagement Work Group, what it is, and how it came to be, and then also a little bit of background timeline of what's been happening in Missouri. We will talk about the payment recommendations that have come out of our work group, and then Jess will talk to you a little bit about the strategy we've employed and our next steps. So the Payer Engagement Work Group is something that was born out of our statewide Community Health Worker Advisory Committee. This committee was formed in 2015 through our Department of Health and Senior Services, who is implementing a CDC grant and supporting community health worker initiatives throughout the state of Missouri. It was formed with the following priorities that you see on the slide, many of which the Community Health Worker Advisory Committee has made its recommendations on, including codifying our core competencies, which will support and are the pillars of our training and curriculum at the community colleges throughout the state. We have made recommendations on a certification process and plan to begin work with the credentialing board on what that will look like. And the final priority is community health worker sustainability and payment recommendations, which we are currently in the process of developing with the statewide advisory committee and the Payer Engagement Work Group. Another key accomplishment in Missouri is that in 2016, our Medicaid agency funded a community health worker pilot through its primary care health homes. And so that was, a key success for us in Medicaid, showing interest in funding community health workers. In 2017, our Primary Care Association also received funding to support community health workers at FQHCs across the state of Missouri. Another key success for us. And then in the fall of 2007, I think we like to highlight that we see the growing movement in Missouri, that we had the highest second attendance at the Unity Conference of annual community health worker convening, and we're really proud of that in the movement that's being made here in Missouri in such a short period of time. And then in 2017, the Payer Engagement Work Group was formed with endorsement from the State Department of Health and Senior Services and our statewide advisory committee, which is made up of representatives of all those involved in community health worker activities across the state. We formed really to bring a collective voice and vision to sustainable payment for community health workers. We think there's strength in numbers and really creating a pathway to make sure that the community health worker voice is represented in any payment recommendations that are put forward. And then we were successful in getting managed care companies to engage and join our statewide advisory committee just this past spring. And then finally, the Payer Engagement Work Group, we presented some Medicaid payment recommendations on May 3rd of this year, and we'll talk a little bit more about that on further slides. I will just give a little bit of background, a little more background on the Payer Engagement Work Group itself. It was formed, it's co-facilitated by myself and Jess. I'm from the Kansas City side, she's from the St. Louis side. Of course, it's open and is representative of the entire state, but we formed this work group to bring together diverse voices from across our state to promote the implementation of sustainable financing streams for programs in Missouri, make sure that the on-the-ground perspective is represented in the design of reimbursement structures. I will say we have a very diverse community health worker programming across the state. It's, in clinical settings, in non-clinical settings, and we want all of those perspectives to be represented in any design of reimbursement to ensure that they're all they all have the ability to be sustained in the long term. And then we're also engaging national thought leaders in this process to help us with our thinking and framing around the issues and learning from other lessons in other states when we frame reimbursement options. Again, it's open to anyone in the statewide advisory committee. We have participation from our primary care association, health partners, community organizations, and local planning groups. To date, we have completed ROI matrix research on ROI that we share with potential payers, showing the impact of community health worker interventions. We have put together policy memos and recommendations on payment models and payer sources, and we have engaged the Medicaid managed care companies. I would just like to note that the work of the work group is grounded in the core community health worker core values from the American Association of Community Health Workers. We keep in mind these core values in all that we do and all that we advocate for to ensure that these are appropriately endorsed and reflected in our recommendations. Jess, is there anything you want to mention about that slide before I move on?
Just in particular, once again, these values are set by the American Association of Community Health Workers. That's led by a majority of health workers who are, setting these values for the workforce across the country. And so, to honor that this is part of the workforce. Once again, we really try to lift up health worker voice to live out that value of self-determination that you see. And with that, if we're not doing that as allies, these other values, they really can't come to full form.
Okay, thanks, Jess. Okay, moving along, Medicaid payment recommendations. As I mentioned in our timeline, on May 3rd, the Payer Engagement Workgroup presented a framework for Medicaid payment to our statewide Community Health Worker Advisory Committee. That committee includes representation from our Medicaid agency, state representation from the Department of Health and Senior Services, many community health worker educators, community health workers, those that operate community health worker programs, so it's a very diverse group. And we offered suggestions on different reimbursement models that can be used to fund community health worker programs, and the benefits and limitations of different models, such as shared savings, fee-for-service, or per member per month. We identified the most promising pathways for Medicaid reimbursement in Missouri. We recommended looking at a state plan amendment. We do know that our Medicaid agency is considering a state plan amendment, and that is an important component for Missouri due to the fact that not all of our Medicaid clients are in managed care, so we wanted to acknowledge that as a pathway and comment and provide our recommendations on the core pillars of a state plan amendment, but at the same time recognize that we do have many clients in managed care and that a state plan amendment is limited, so we would consider that only one component of a broad approach to reimbursement for Missouri. And we recommended that the development of the specific components of managed care requirements and the state plan amendment be an inclusive process that stakeholders through the statewide advisory committee, the state and CMS are able to work together to develop those components in contract language. In terms of the state plan amendment, our work group recommended that it's broad. It targets a broad population. This is due to the fact that we have a variety of community health worker programs in Missouri, and they touch a variety of populations, and that limiting to a specific chronic condition, for example, would restrict some of the programs from being able to benefit from a reimbursement model under a state plan amendment. We recommend that this is key the alignment with scope of practice as broadly as possible, and this is a limitation with the state plan amendment from our perspective, is that the community health worker scope of practice is broad and is appropriately broad. And that in one client interaction, a community health worker can provide, health education, care coordination, individual support. And that's really the strength of the intervention from our perspective. And that aligning a state plan amendment with that scope of practice as broadly as possible is key, but may not be, may not be functional under the CMS requirements, especially the sub-regulatory guidance, which really narrows and limits the preventative services that can be provided under that state plan amendment. So we want it to be as broad as possible. And then we also want it to align with the core competencies, any qualifications to align with the core competencies that we've set out at the statewide advisory committee level. And then finally, as another component to a broad approach to reimbursement is that our Medicaid managed care companies should be required to contract with local providers and community organizations delivering the community health worker services. And this could allow for reimbursement for the broad scope of practice and under a variety of payment models per member per month, a case rate. So a variety of payment models. We think this is these two state plan amendment and Medicaid contracts should be considered together. The state plan amendment, in our opinion, is a building block, and the managed care contracts can allow for broad application to really maintain the integrity of the scope of practice. And then I will now hand it over to Jess.
Hi, so we also wanted to share a little bit about the engagement strategy in engaging our local communities and engaging agencies at the statewide level as well. So a little bit about what we've done there. As Erica mentioned, we had presented our payer engagement work group's recommendations at a meeting to the full statewide CHW advisory committee. And just to give you a sense of the work that went into that, I'd say it was maybe perhaps 9 months to a year's worth of coalition building, really engaging our managed care organizations to get involved at the table, preparing our community health workers to really understand the mechanisms of reimbursement structures and then become involved in shaping the way those look. And so you see that we had a lot of different audiences represented at that meeting to really frankly build out a democratic process. The other thing I'd like to just mention and go back to a slide very briefly, just 1 second. Back to this timeline, what I'd like to share is that meeting was May 3rd, 2018, where we've had this opportunity to, inform and influence this, Bob, but we've really approached this along the way as an opportunity to coalition build, not only locally within our regions, but then build partnership, with statewide agencies along the way to, again, have tables that are working in alignment and with one another around this shared goal to live out the full value of the community health worker workforce and scale and sustain it. So 1 moment, let me move back to this other slide. So, like other partners, and like Joel shared earlier, what we really have found a lot of value in is, the value of collaboration and partnership in this coalition building. So once again, at that meeting and then throughout the process along the way in building recommendations with our statewide payer engagement work group, what we've tried to do is really operate in a democratic and consensus building sort of way. So at the meeting, what we tried to do was verbally affirm that each recommendation with the stakeholders with the stakeholders present, we just really wanted to verbally affirm each strategy and the framing of the recommendations for the SPA and beyond. One thing that really stood out, though, from our very vocal community health worker leaders in the room was how, some current form of the SPA had a very limited scope of practice on preventive services. They shared a lot of really helpful feedback on how that limited scope of practice would impact what they could do out in the community. One example in particular that comes to mind was a woman from the St. Louis region who works with children with behavioral health as part of her health worker service. She goes to a lot of IEP meetings at schools to advocate for her clients as part of, the work of really living out practice around the social determinants of health. The current scope of practice wouldn't allow her to do that or would significantly limit her ability to do that kind of work, which we know addressing the social determinants of health is a crucial function of what community health workers do. So along with that, what we'd like to share and, as next steps that we see in the process, since we're really sort of in the middle of this right now, are, first to celebrate some successes and challenges that we've had. One success for our state as a whole is the active involvement of community health worker decision making, and for the St. Louis and Kansas City regions, we're actually also strategizing on ways that we can continue to train our community health workers in leadership and advocacy to really strengthen and build their capacity to do more of this work. In addition, we're working locally to train our providers on how to receive and think in innovative ways to incorporate the input that community health workers are giving around how the system could transform. Another success, as we mentioned, that we really celebrate is the multitude of audiences that have come together in alignment around this work and have been very vocal and, again, participated in a process that was very democratic. And the way that we have leveraged our multiple statewide tables to make recommendations to Missouri's Medicaid agency around how this reimbursement structure could be designed to support the work of the health workers. One challenge that we do foresee in Missouri, we're very fortunate to have community health worker coalitions in the St. Louis region, in the Kansas City region. We're fortunate in our urban areas to have enough support and partners to do that work. In our rural areas, there's less resource and partnerships available for them to do that. And in a state like Missouri, it is very important to have that representation, that rural representation across Missouri. That limited capacity for the rural areas to do that work. It actually came up in a coalition meeting yesterday. They'd like the opportunity to be able to do that so they can advocate with their voices as well. Fortunately, our Department of Health is exploring creation of a community health worker association, and that could be a vehicle for that kind of work. But those multiple voices from multiple regions are very important as we continue discussing what this structure could look like with our Medicaid agency. Finally, what we'd like to share in terms of our next steps are the state plan amendment. Once it's submitted to CMS, we are actively working with our work group to prepare for a response to that. We're fortunate to have a partnership with our managed care organizations, Missouri Care in particular, who has offered some thought partnership on the way that we can design certain codes and leverage those codes to build an inclusive reimbursement strategy. We are thoughtful as well to not just focus on any one strategy, but build out sort of a menu of different funding stream options beyond Medicaid to, prepare for sustainability through a lot of other channels. And then with Missouri being a non-Medicaid expanded state, it's very important for us to think about strategy to to figure out how we serve the uninsured in Missouri. And so along with these discussions, we'll be actively exploring ways that we can fund parts and portions of a CHW service for uninsured populations across Missouri.